Hyperandrogenism means the body makes or receives too much male-type hormone. It shows up most often in women and can cause unwanted hair growth, acne, and menstrual problems. Doctors have been studying it for decades, especially because it is a key feature of polycystic ovary syndrome. The condition reflects an imbalance in the hormonal ecosystem that normally regulates reproductive and metabolic functions. The ovaries, conditions like PCOS or rare ovarian tumors. The adrenal glands, disorders such as congenital adrenal hyperplasia or adrenal tumors. Medicines or steroids that people take on purpose, for example, bodybuilding drugs or by accident. Inherited genetic defects that affect hormone production. Each source feeds the bloodstream with excess androgen, which then acts on peripheral tissues. Androgens are made through a step-by-step chemical pathway called steroidogenesis. If an enzyme in this pathway works too fast or is missing, extra androgen is produced. Some people also have more sensitive androgen receptors, so normal hormone levels feel high. These changes upset the normal feedback loop between the brain, pituitary gland, and ovaries and adrenals, keeping the system stuck in a high androgen state. About 5 to 10% of women of reproductive age show signs of excess androgen, most often because of PCOS. It can start in teenage years and is more common in overweight individuals. While women are the primary group affected, men can have hyperandrogenism from adrenal or tumor causes. Prevalence varies by ethnicity, with higher rates reported in Mediterranean and South Asian populations. Typical signs are skin-related: excess facial or body hair, hirsutism, oily acne, and thinning hair on the scalp, alopecia. Reproductive clues include irregular periods or difficulty getting pregnant. Metabolic problems such as insulin resistance and weight gain often accompany the hormone excess. In severe cases, a deeper voice or an enlarged clitoris may appear, which can affect confidence and daily life. Doctors first use a visual scoring tool, like the Ferriman-Galway scale, to count hair in different areas. Blood tests check total testosterone, DHEAS, androstenedione, and sometimes 17-hydroxyprogesterone. Ultrasound looks at the ovaries, while CT or MRI can spot adrenal tumors. Special tests, a CTH or GnRH stimulation, help tell if the source is adrenal or ovarian. The results are compared with a checklist of other conditions that can mimic hyperandrogenism. Hyperandrogenism can be split into primary or secondary. Primary, the problem starts in the hormone-producing organ. Secondary, the brain signaling is off. It can also be ovarian dominant, adrenal dominant, functional, or neoplastic. Functional, like PCOS, where the glands work harder but are not a tumor. Neoplastic, actual tumors. Congenital adrenal hyperplasia is a genetic subtype that presents early in life. First step, lifestyle changes. Losing weight, eating a balanced diet, and exercising can lower insulin and androgen levels. Medicines include antiandrogens, spironolactone blocks androgen receptors, combined oral contraceptives, reduce ovarian androgen production, metformin improves insulin sensitivity, and steroidogenesis inhibitors, ketoconazole. If a tumor is found, surgery to remove it may cure the excess. Specific problems such as infertility are managed with fertility drugs or assisted reproduction. Regular follow-up checks hormone levels and symptom scores. Preventing hyperandrogenism focuses on controlling risk factors, maintain a healthy weight, avoid non-prescribed anabolic steroids, and screen family members with known genetic disorders. Early testing for teenage girls with strong acne or hirsutism can catch problems before they worsen. Genetic counseling helps families understand inheritance patterns of conditions like congenital adrenal hyperplasia. When treated, most women see a reduction in hirsutism and improvement in menstrual cycles within months, but skin changes may take longer. Long-term, untreated excess androgen raises the risk of type 2 diabetes, heart disease, and ongoing fertility issues. Good management can keep these risks low and improve quality of life. New research is looking for precise biomarkers, like specific blood peptides, that tell doctors exactly where the excess androgen comes from. Selective androgen receptor modulators, SARMs, and newer aromatase inhibitors are being tested for fewer side effects. Genetic studies are uncovering how DNA changes affect PCOS risk, and advanced MRI techniques help locate tiny adrenal tumors that were missed before. Ongoing trials combine diet, exercise, and low-dose medication to see if a holistic approach works better than drugs alone.